Hello everyone, you are watching Physio Classroom channel, and in today's video we are going to discuss the third proprioceptive neuromuscular facilitation technique, which is known as reversal of antagonist. Now reversal of antagonist is again subdivided into three subtypes, which are known as the dynamic reversals, the stabilizing reversals, and rhythmic stabilization. Now all these techniques are based on the Sherrington's principle of successive induction, which states that increased excitation of the agonist muscle is followed up by increased contraction of their antagonist. Now the previous two techniques that we discussed in detail, that is the rhythmic initiation technique and the combination of isotonic, both were emphasizing on activation of a single group of muscle, which is only the agonist were being emphasized. And unlike the previous two techniques, in reversal of antagonist, we are going to concentrate both on the agonist as well as the antagonist group of muscles. So let's start knowing more about the reversal of antagonist technique by discussing the first subtype, which is known as the dynamic reversal or slow reversal. So dynamic reversals are characterized by active motions by the patient from one direction to the other without any pause or relaxation. In our daily life, we often see such kind of activity like walking, cycling, throwing a ball, etc. The dynamic reversal techniques can be utilized by the therapist in neurorehabilitation to improve active range of motion, improving strength and coordination, improving endurance, and reducing fatigue. So today I have with me Shubham Pandey, who is a physiotherapy intern here at SRHU University, Dehradun, and together me and Shubham are going to discuss and demonstrate in detail all the three subtypes of reversal of antagonist technique. So let's say Shubham is having difficulty in completing the elbow extension range of motion. So that means his active range of elbow extension movement is limited. Now there could be various causes that could be attributed to this problem. Some of them could be poor motor control for the elbow extension movement, joint stiffness, or decreased strength in the elbow extensors. So now we have our therapeutic goal, which is to improve the active range of elbow extension movement in this patient. So now the next step in planning of the exercise should be to choose a functional task or an activity that demands the dynamic reversal of the movement. So now, for example, in this case, I have chosen the activity for this patient to wipe the table. Now, as you can see, wiping is also demanding the activation of the flexor as well as the extensor group of muscles. So let's see how dynamic reversal technique can be applied in this condition. Now please note, I am deliberately not choosing to show PNF patterns in the demonstration for the techniques, as I want to emphasize on the point that PNF therapy can be practiced by therapists by only knowing the PNF philosophy and concept of treatment. Knowledge of patterns is not essential for practicing PNF therapy. Okay, so let's start by instructing the patient before we start the exercise. Now Shubham, as you know that there is problem in extending your elbow, so what I want you to do is to try and cover as much area of the table as you can by wiping it inwards and outwards. Okay, you also need to focus on my command, as I would be resisting your hand movements. Okay, so let's begin. So now what I'm going to do is I'm going to use one distal and one proximal grip, and I'm going to resist the Shubham's effort of completing the motion in both the directions. My distal grip is going to resist the radial deviation and the elbow flexion movement, whereas my proximal grip is going to resist the internal rotation movement, which will occur along with elbow flexion, and the external rotation movement of the shoulder, which is going to occur during elbow extension. The two important things that should be practiced by the therapist are the timing of the command and the change of the proximal and the distal grips while practicing dynamic reversals. So when the patient is going to go towards the flexion motion of the elbow joint, my distal grip is going to resist the radial side and my proximal grip is going to resist the internal rotation of the shoulder. When I will see that the patient is going to achieve the end range of elbow flexion movement, I am going to change only my distal grip from the radial to the ulnar side and now give command to the patient to start putting effort against my resistance for elbow extension movement. And when I find that the patient has started resisting or putting effort against the therapist's resistance, then I can change my proximal grip and start resisting the shoulder external rotation. So let's see how dynamic reversal will look like. Shubham, wipe in, good, wipe the table inwards, good, good, good. Now wipe out, wipe out, wipe out, wipe out, good. Now wipe in, wipe in, wipe in, wipe in, good. Now wipe out, wipe out, wipe out, very nice. Now wipe in, wipe in, wipe in, good, good. Now wipe out, very nice, and relax. Now dynamic reversals are characterized by motions changing directions without any pause or relaxation. But in modification, we can also incorporate the stabilization component along with dynamic reversals, in which when the patient achieves the end range of motion, instead of reversing the grip at the end range and asking for an effort to move the limb into the newer direction, the therapist can just ask the patient to hold the position and do not let me bend your elbow further, do not let me bend your elbow further. And when the patient has started contributing enough, we can ask for the motion, extend your elbow and wipe the table. Good. So this was all about the first subcategory of reversal of antagonist technique, which was called as dynamic reversal or slow reversal. Now the next subtype is known as the stabilizing reversal technique. So let's just quickly demonstrate. Now the stabilizing reversals are characterized by alternating isotonic contractions of agonist and antagonist, which are resisted by the therapist so that no or very little motion is produced. Stabilizing reversals can be chosen as a treatment of choice to improve the stability of the patient or strength or improving coordination between the agonist and the antagonist group of muscles. Just remember that stabilizing reversals demands the stabilizing isotonic type of contraction between the agonist and the antagonist group of muscles. So let's see how we can improve the trunk stability using stabilizing reversals. Now Shubham, I am going to place my hand behind your shoulders, and when I say don't let me pull you forward, you need to match my resistance or my effort. Good, good, good. I might allow Shubham to produce some motion. When I find that Shubham has started matching my resistance and is able to produce some motion in the backward direction, I'm going to bring one hand forward and now I'm going to ask Shubham, do not let me push you back, not let me push you back. And when he starts matching the resistance, I'm going to bring the other hand also and give the same command, do not let me push you back. I can allow Shubham to produce some motion in the forward direction. Again, I'm going to change one hand, do not let me pull you forward. He matches my resistance. I bring the other hand back, do not let me pull you forward. I might allow some motion. And then again, when I find that he is matching my resistance, I bring the other hand here, do not let me push you back. He matches my resistance. I might allow some motion. Bring both hands forward, do not let me push you back. Good. Now we can start with the slow reversal technique and then move to dynamic reversals. We can also change the positioning of the resistance hand so that we engage much larger group of muscles. Like for example, my initial positioning of the hand was right behind the shoulder and anterior to the shoulder. I might also keep on changing the hand positioning by moving it more back and down or more front and down. So in that way I can engage more muscles into the action. We can also start with slow reversals or dynamic reversals and then progress to stabilizing reversals to improve truncal coordination and stability. Let's see how. So Shubham, now you need to reach down when I say reach down, and you need to come back to your neutral position when I say come back. Just keep following my commands of reaching down and coming back. Okay, let's start. Reach down, good. And now come back, reach down, and now come back, reach down, and come back. Now I'm gradually decreasing the range of motion. Reach down, come back, reach down and come back, reach down and come back, reach down and come back. Now don't let me pull you forward. Good. Don't let me push you back. Don't let me pull you forward. Don't let me push you back. Don't let me pull you forward. Good. Now the third subcategory of reversal of antagonist is known as rhythmic stabilization. Now there is not much difference between rhythmic stabilization and stabilizing reversal, except that in rhythmic stabilization, alternating isometric contractions of the agonist and antagonist are produced, whereas in the stabilizing reversals, alternating isotonic stabilizing contractions were being produced. In rhythmic stabilization, the patient is instructed to match the therapist command, which is hold and match against my resistance, so that no motion is intended either by the therapist or by the patient. So Shubham, stay there and hold your position. Do not let me push you back. Hold, stay there, hold, very nice, hold. Now stay here and do not let me push you forward. Hold, keep matching my resistance, good. Hold your position, hold. Now hold your position, hold. One of the major advantage of rhythmic stabilization technique as compared to the other two techniques of reversal of antagonist is that it can also be used to induce pain relief. That is, we can exercise a joint which is distal to the painful joint, like for example, the shoulder is painful, then we can practice the rhythmic stabilization technique for the elbow joint, and in that way we can help in gaining relaxation at the shoulder joint. So in summary, larger movements of agonist and antagonist are referred to as dynamic reversals, whereas very little motion of agonist and antagonist is referred to as stabilizing reversals, and isometric contractions with no motion intended is referred to as rhythmic stabilization. This is a humongous task that we are trying to do of making PNF therapy simplified for the students and young practitioners, and we need your support and motivation for the same. Please do keep giving us your valuable feedbacks, and in the end, as I always like to mention and say, keep learning,
keep sharing,
and stay connected.